walking. So can I just get you to walk up and down? Yep. So as you know, gait pattern is all, it's kind of, you've got stance phase and swing phase. The stance phase is the heel strike, the flat foot, and the toe off, as you probably know.
Because my socks off, you're right.
Yeah, go on. So, and obviously I'm looking for what their gait pattern's like. You know, are they limping? Have they got, you know, and then we can split down what their gait is. Is it antalgic? Is it short leg, etc., etc. So they're just different things we're looking at. So I'm going to watch them do that, and that's important for what they're doing, and also especially that's great. And then especially important for I really want to watch my post-op patients walk as well. It's really interesting to see what they're doing gait-wise. So let's get you to sort of stand here. The next thing is, and we're going to get slightly on actually. We're going to do Trendelenburg testing. So, Trendelenburg test is really essentially looking at glute function, okay, and lots of different ways of doing it. My way is I put my hand on anterior, superior iliac spines. I'll try here somewhere. There we go. And I'm kind of looking to see how level my hands are. And all that's going to happen is I'm going to get you. Now you can, if you're concerned that the patient is going to fall over, you're worried, you could get them to just put their hands. Are you okay with your wrist here?
Yes.
Is that Mark Phillips's examination? So if you're worried about it, you can, you know, I could stand up and put my hands underneath them, or they can put their hands on my shoulder, but they just get to support themselves. That's all, so they don't fall over. But all I'm going to get you to do, you're going to lift, and instead you don't lift forwards, you take your leg backwards. So you just bend the knee backwards, and it doesn't matter which one, just get back one side. And I'm just trying to make sure my hands are not dropping down to one side on the weak hip, okay, and then back down again, and then the other way. So we got, and there's lots of different ways. This is one way of doing it. Another way of doing it, that's right. Is you can then get them to put their hands on yours and then stop them from leaning over too far, so they're not compensating that way. That's just telling me what their glute function is like. Patients who have, for example, femoroacetabular impingement, they'll usually, a lot of them will all be Trendelenburg positive. It's a very early sign. They get that glute weakness, and they're weak in their glutes because actually a lot of these patients tend to have quite, they've got a very poor pelvic plane positioning and control. So patients with FAI or early arthritis tend to have quite a forward tip pelvis. When you're tipped forwards, it's a very poor position from the core perspective and very poor from the glute perspective. So, you know, I can't tighten my bum up. It's really hard in this position. When I tip back, now I can tighten it up. And what you'll then find is patients, when they are tipped forwards, they're using less glute to walk, and therefore they're inflaming what small amount of glute they've got that they're using. So just something to think about for how you might want to, when you first see these patients. We're obviously thinking about that pelvic plane position and correcting the pelvic plane. So the other bit on stance is that I'm going to look around the hip, look for scars and swelling in the sinuses, etc. You know, have they had a replacement before, etc. So I'm looking at that. I've done my Trendelenburg, and then supine limb length. Okay, so tape measure, bony landmarks, real limb length would be, and when they're lying flat, make sure they're level, make sure your couch is not too soft. And then you can measure up. So there's different ways. Sure, you can come to the bottom of the bed and just feel where their medial malleoli are, provided they are level and in line. That's pretty inaccurate. You can get a ruler, or sorry, a tape measure, and then you're going to measure down. Anterior superior iliac to medial malleolus, do both sides. And that's going to give you a real limb length. An apparent limb length is going to go from a bony landmark on the midline, so ziphisternum ideally, again down to those points, and you can get an idea of what their apparent limb length is. It should not be a landmark that moves. So belly button is a no. Now, how accurate is this? What does it really mean? I mean, to be honest with you, if you really, I mean, in this day and age, if you want to know limb length, everyone should be in a CT scanner. Okay, so standing them on books and measuring it, it really doesn't mean much, because to be honest with you, what you don't know is how long's their femur, how long's their tibia, what's their interarticular distance like, and you don't know that. You can get that off a CT scan. So really nowadays, to be honest with you, that's really what we should be doing. In my joint replacement practice, everyone gets a 3D CT scan. I know exactly how long the legs are, and when we're reconstructing them in a 3D plane to literally within a millimetre or two, and that's how we do it. So no one gets a long leg or a short leg or anything like that. So that's the key thing there. Also, yes, I'm going to palpate. So when they're supine, I'm going to get anterior, lateral, posterior when I get them in a lateral position, and just feeling for the tender spots. You know, where are they complaining of the pain? Does it hurt there? Somebody with a labral tear, I know I keep talking about labral tears, but somebody with a labral tear, you can't really get your finger on the pain spot. They will tell you where their pain is. When we test them out for a labral tear, then we'll then create that discomfort for them. But as for trying to get your finger on the spot, so don't expect that one. And then the next sort of thing I do is then Thomas test. Now Thomas test is looking for fixed flexion deformity of the hip joint. Again, lots of different ways of doing it. Can I, what I'm going to get you to do, so one way, for example, is you hang on to your leg there, and I'm going to get you to hang on to your leg up there, so you're going to do both. So you can do one, but you can do both. If you've got both, and then you get them right up into as far flexion as you can. Now obviously old Gran is going to have difficulty doing this potentially. I'm trying to confirm there's no, I've obliterated the lumbar lordosis, that's all I'm doing by this manoeuvre. When I'm happy that that's the case, we'll just let one leg down. So we're going to let that leg down, and I want to make sure that this is going to the table and that I can't pass my hand underneath it, which I can't. And, okay. Sure you haven't got there. And then we put the other one down and I can't again there. So that's all I'm trying to do. Now, that's a nice bit of info to know on a joint replacement patient, because if I've got somebody with a fixed flexion deformity, they've got anterior structures that have never been into full hip extension. So post-operatively, if you're then trying to mobilise them and get them going, you've got to take that into account. That should be part of your programme of getting them out there, because what will happen is when they're walking, if they've always been slightly flexed and unable to get into that hip extension position, when they're walking, what's going to happen is they're not going to want to come out into hip extension. Okay, so just something to watch out for, because obviously I've replaced the joint, all the osteophyte's gone, that hip can kind of go wherever it wants. So just something to bear in mind, because those patients, you stretch them out and you actually probably irritate their rec fem, for example. And then we're going to go straight leg raise. So I just do that as a general test, looking at various things. So can I just get you just to lift your leg up? So I want to know, have they got a back issue? How tight are their hamstrings? What's their strength like in their quadriceps? How flexible are they? Are they actually able to get up? Now here, hammy is a little bit more tight.
Yeah.
Okay, so, and they are a bit. I think what you can do is take them up into full 90-degree hip flexion, then extend out, and tell us when you're feeling it. Actually, not too bad. So if we're going to go 0 there, anywhere up to about 20 degrees, possibly 30, would be considered to be actually acceptable. But I think if you're probably right in the limit, you're really as tight as anything. But if somebody was kind of down, that'd be really, really tight. So that's something to work on. And also something very much to bear in mind, because patients who are really tight in their hamstrings, then they're probably going to be quite hamstring dominant. They'd probably be very glute weak. For a hip patient, that's a disaster. You want the glutes to be dominant because you want that glute centering the ball in the socket. You don't want the hamstring driving the femoral head out the front of the socket. So that's really key. And then obviously when I'm up here, then I'm going to put this hip through a range of motion. So hip flexion is the first thing. That's all right, you okay?
Yeah.
Good. So he's got, obviously great hip flexion here. And then from a 90 position, we're going to check internal rotation, and he's got 45. Which is normal. I kind of say 45 is good. He's probably got about 55 of external rotation, and that's all good range. Now, I'll come to special test in a minute, but that flexion, adduction, internal rotation position, as you know, is quadrant testing, and that's giving me an idea as to whether they may or may not have, a labral tear. And then I'm going to drop them back down again, and then take them into abduction. So fix the pelvis, because that's really important, and then see how much. And he's got great 50 plus degrees of adduction. Adduction, obviously the other thigh gets in the way, which doesn't help, but he's got a good range. Again, an arthritic patient will have a reduced range. You'll feel that pelvis moving with you. And then you can roll them as well for internal, external rotation and extension. It's not a great test, to be honest with you. Most people are not going to have less comfort from that. That loss of internal rotation is an early sign of arthritis of the hip. So that's our range. Okay, thank you very much. That's very kind. Special tests. So, now, so I mentioned this business of impingement. So flexion, adduction, internal rotation. All I'm doing here is smacking femoral neck against edge of socket. So somebody with a labral tear or labral inflammation, so it doesn't have to be torn, they will find that uncomfortable. So you must compare to the other side. So all I'm doing is I'm coming up, rotating, and all I'm trying to do is catch that bit of labour. So if that is uncomfortable for somebody or painful, and don't forget we must compare to the other side, a lot of people will find that they might say it's stiff, but it is quite an uncomfortable manoeuvre anyway. You've got to compare to the other side and just say, look, is that any different? And they, of course, will say, yeah, it is, that hurts. So watch out for that. Now, all that's doing for you is just telling you there might be something wrong, because that test can be positive for a bunch of things. If they've got a femoral neck stress fracture, it will hurt. So that's the thing to watch out for. So, but it's just telling you, okay, you know what, there might be something going on here. I'm going to log that one. Let's keep an eye on that. Maybe they need, they're going to need an MRI scan, who knows. So, but you should be then thinking, right, something's happening. You should not be ignoring that. So that's what we do if we're thinking of labral tear, and it's Fadir test is for an anterior or anterior superior labral tear, and Faber, which we know is an SI test, is also for potentially a posterior labral tear. So I'll take somebody out and I'll go flexion and I'll rotate them. Okay, so that's something else I'm just looking for in testing for my labral tear. The extreme positions all the way around, that's my femoral neck fracture, okay, that I'm also looking for, as in stress fracture. And the other thing you can do if you're looking for a femoral neck stress fracture is percussion testing. So percussion testing is you just lift the leg off and you whack the heel, okay, with just your fist, or come up to knee flexion and smack the front of the knee like that. I don't do that one personally, but it's something you can do. And the other one is smacking their great trochanter. And somebody with a femoral neck stress fracture, that will help. Okay, well, they'll feel it. So that's what we do for stress fractures. And then we've got snapping hip. Okay, so with snapping hip, we've got two types of snap. You've got an internal snapping hip, which relates to the iliopsoas, and you've got an external snapping hip, so forgive me, these are Americanisms. External snapping hip is for iliotibial band, over the great trochanter. Now, patients that you see with snapping hips, they will demonstrate that to you. It's their party trick, they will show you. So, but if you're going to try and elicit it yourself, for an internal snapping hip, which is iliopsoas tendon rubbing over a little bump on the acetabular brim stroke pelvic brim, usually they'll go from a Faber type position, so flexion, abduction, internal rotation, and they drive their leg down, internally rotating as they extend and adduct. And what that motion does, that rotation from up here downwards, is they're taking surface and it's going to rub over that little bump, and that's what gives you a little click or bump or snap. So that's that one. Treatment for those patients. So usually it's dancers actually. Ballet dance is the classic one. So you need to stretch them out. You've got to calm it down. That's your anti-inflammatories. Confirm it with an ultrasound. Maybe fast some steroidantic. Calm it down that way. Very rare they ever need any kind of surgery. If you do, it's arthroscopic, and all you do is divide the tendinous portion, but leave the muscle belly. I'm always loath to ever want to do anything like that, but because I think great therapy can sort them out. So that's internal slap. External slap is that IT band, and again, usually they'll stand and they can wiggle their hip around and show you and demonstrate it, to be honest with you. We've got a couple of ways of testing for that. And again, same thing, therapy, they'll have a trot bursitis, calm that bursa down, so again, ultrasound, guided injection, etc. They're all things that we can do, again, all conservative. And sure enough, yes, you can always throw some surgery at them if they're really resistant. And all that involves is just basically making when I say a hole, you make an H incision in the iliotibial band. That gives a bit of space for the great trochanter to actually move through, but you still maintain the integrity of the IT band, which is what you want to do. Cutting straight across it is not the thing to do. But would you believe there are people that do that? So, so that's your snapping hip. And then somebody with an eye, can I get you to go actually on the side? So just to kind of show you a bit of that. So lateral position, we're going to bring the hip into extension, ideally, and you hold the leg, and quite simply you just put your hand on top of their GT, and then you can literally roll them around one way or the other, and you can feel it literally pinging under your fingers, which they'll recognise. Somebody asked me in the last group, well, if they have a snap and it's not painful, would you do anything about it? And kind of my answer is, well, no, I personally wouldn't. I just want to, maybe do everything we can do to stretch them out, but wouldn't necessarily want to do anything. If it's painful for them and a problem, well, yeah, okay, then we can start going down that route of doing things. But obviously, hopefully, we want to try and avoid the surgery. Ober's test is just an IT band test. Quite simply, it's a hip extension, as you know, somebody with a really tight IT band, bring them out to hip extension, and when you try and drop their knees down, either extension or even a certain amount of flexion, one, that's uncomfortable, two, their knees just won't meet because they're so stretched out if they've got a really bad, tight IT band. So again, treatment for that, as you know, you've got to do all your work, foam rolling them, etc., and then treating the sore bits. And usually you find it's not just IT band, it's a bunch of other structures with it as well. So look at the hamstrings, etc., and make sure they're nice and loose. And then as for SIJ, have you guys done this? You should. I think you're covering this in spine. Have you done spine? No. Okay, you are covering, but very quickly. Faber, as I've mentioned, I'll jump here from, so I'll come back to that. Stalk test. The stalk is so you stand behind the patient, get them to stand on the affected leg, so they lift their other leg out of the way, and then you put your hand on their SI joint and you get them to extend, hyperextend back, and that should be uncomfortable for them if they've got an SI problem. Your other route is, again, lateral position. You kind of do this stretched out Faber. So again, you kind of take them right the way over and get their leg right the way over the other side, force it down. Fine enough.